the final segment on provider payment mechanisms. So Warren, I see you're sharing your screen.
Yeah, I see if I can make it go to full screen mode here. There. Okay. I will try to move through this efficiently. In May of 2019, the Congressional Budget Office, commonly referred to as the CBO, released a report entitled Key Design Components and Considerations for Establishing a Single-Payer Health System. Mid-Valley has been working its way around this circle of seven elements in the circle and 12 questions related to those. The last one we did was in August on cost containment and financing. And Mark had volunteered to do the one on payment rates. As mentioned, when it became apparent that Mark was not going to be able to give a report himself, I'm volunteered to act as a stand-in to work from his excellent summary and notes. This section of the CBO is divided into 3 subsections. What are the possible payment provider methods? How do you determine the actual rates that will be paid? And the CBO adds some comments on the implications of the alternative methods and rates. This is the longest section in the CBO report, and probably suits Mark that he picked the longest section of this 32-page report to summarize. What are the payment methods? CBO report offers 5 methods which could be used for making payments to providers. Fee for service, bundled or episode-based payments, global budgets, capitated payments, and placing providers on salary. Going through these 5 models one by one, the fee for service model works by the provider presenting a detailed bill of the services which were provided in every patient encounter. Examples of where used, US and Canada, as well as many other countries, although it doesn't work the same in all countries. Who is at risk? The payer, whether an insurance company, self-insured employer, or the patient themselves, they are at risk from healthcare costs. The CBO notes that the fee-for-service model gives providers an incentive for more expensive and more extensive care options. Other criticisms about the fee-for-service model is that it rewards complex billing, which can have high administrative costs. The more complex that you can make the bill, the more money you can get. There are now whole college degrees on how to choose between literally tens of thousands of possible codes to get the most money out of every patient encounter. Since the billing codes allow charging more for taking some medical action instead of just talking with the patient, a doctor who places a patient on a lifetime prescription of Nexium makes more money than my doctor did when he suggested avoiding taking a nap in the recliner after eating pizza. With the fee-for-service model, providers can get paid more if the outcome is poor and requires additional treatment. And the motivation for higher billing revenue helps drive higher cost specialization. The bundled episode payment model works by paying the provider a set amount for all care related to a specific medical problem. Examples of where used, Medicare is trying this for joint replacement. It's used for some hospitals in England. Who is at risk? The provider is at risk if the cost of care exceeds the set amount accepted as full payment for the episode. The CBO comments that the bundled episode model gives an incentive to the provider to keep creating new episodes so that they can get more money to inflate the diagnoses. The CBO expresses concern that providers receiving a set payment may end up withholding beneficial care to stay in budget. Other comments, it actually evidenced that it is currently helping contain cost without loss of quality. The global budget model, the provider receives a set operating amount per time period, usually a year. Some adjustments may be allowed when conditions change during the year. Examples of where used: Maryland uses this in their multi-payer system for hospitals. Canada uses it for hospitals, and it's used to some extent in almost all other single-payer systems internationally. Other examples of global budget outside the healthcare field would include public schools and other public services, where there is just an annual budget and you're sent to go do the job. Under the global budget model, the provider is at risk if treatment costs exceed the payment model. Because the provider is at risk of not being able to provide care if circumstances change during the year, global budgets can sometimes be adjusted during the budget year. The CBO notes that since most global budgets are tied to a country's GDP or to their a community's income tax revenues, any rise in healthcare cost which exceeds the ability of the community to pay places a lot of responsibility on providers to choose how the limited funds will be spent. For those who want to keep costs in line with national and community income, global budgets provide strong leverage for cost containment, keeping the healthcare system effective and efficient. Patients under the VA system, which is a global budget system, generally express higher satisfaction with this globally budgeted system than patients who are in the fee-for-service or bundled payment model. And the doctors I've talked to who have worked for the VA, they love working in that environment where they're not involved in being worried about how to generate the revenue. Next method is capitation. In the capitation payment model, a set amount per patient per time period is paid to a care management organization. Examples of the capitated payment model are Oregon's CCOs, Medicare Advantage, and in England, some GPs are paid a fixed amount to provide certain essential services. Here again, it is the provider or care manager, if different, who is at risk if the cost of care exceeds the capitated payment. The care manager can be a provider, group of providers, or a contracted insurer. In capitated payment models, such as Medicare Advantage, the care managers can attract the most well patients, but use upcoded data to make them look sicker than average. This is a little bit like Lake Wobegon, where all the children are above average. In the Medicare Advantage programs, every Medicare Advantage plan claims that they have the sickest patients and need to have their rates adjusted upwards. The capitated model is the fastest growing model in the US. I'm interjecting my own slide here, showing how the overhead costs of Medicare and Medicaid have been rising quickly as more money is funneled through managed care intermediaries like Medicare Advantage and the CCOs, which are all reimbursed on a capitated payment system. Private insurance has taken about the same cut of the dollars that go through their go through those insurance companies. They've actually been pretty, I can't say steady, it goes up and down with economic cycles, but it is about the same as it was 80 years ago. On the other hand, Medicare and Medicaid funding overhead, the net cost of that insurance that's not going to patients is the two fastest growing components of healthcare cost. Lastly, the salaried model is just what it says. System, and this system, like the previous couple, you know, if you get a global budget or to some extent a capitated payment, or if you work for a salary, then there is no need for billing individual patient encounters, which of course, you know, the real question, which interestingly enough, the CBO doesn't really ask, why are we doing this? Well, of course, one of those reasons is the big savings that's potentially there if you suddenly don't have any people work on billing, either on the provider end or on the payer end. The salaried model is used in the VA, in the English National Health Service, and actually at Kaiser Permanente, to provide a few examples. The CBO claims that low risk for both provider and payer because it has very good predictability. You know who's going to be working. You know what they have to do, and there's very little paperwork that takes place. Some other comments: salaried work may not appeal to some doctors who are attracted to the higher average incomes possible in the fee-for-service model. One model of provider reimbursement that is not included in the CBO report is the fee-for-time model, as suggested by Dr. Stephen Campbell of Hawaii. Fee-for-time model would remove all coding for except for just the amount of time spent with the patient. It's actually what we used to do before things got complicated about 60 years ago. It's an obvious idea that's old enough to be new again. The CBO identifies two ways of actually determine the amount of payment which would be made. One is administrative, that you just establish by law or regulation, not too dissimilar to Medicare and Medicaid. Or the other thing that you do is you negotiate with a set of providers. In the current US system, each individual private insurance company has to negotiate rates with every single separate providing organization. This takes a lot of effort. In other countries such as Canada and England, professional provider organizations help set national fees, rates, and salaries. The CBO in their report suggests that the AMA might be used as the negotiating agencies for providers under a single payer system. And in Mark's notes, there's a little bit of you can tell there's an eye roll here that the AMA negotiating for rates may not be obvious to everyone. The CBO offers a few possible implications of choosing the various alternative methods and rates. If multiple rates are one of their concerns, if multiple rates are allowed, like in private insurance, Medicare and Medicaid, all paying at different rates, providers will seek higher paying customers and limit or drop lower paying customers. When I ask doctors, they all say, no, we've never done that. But there is plenty of evidence that it happens. Regionally determined pricing can create high disparities based on factors other than healthcare, Certainly, we've seen political manipulations of some states get higher Medicaid reimbursement than other states, for instance, in doing this in a setting the rates in administratively. The CBAO notes that any change in payment system is likely to be disruptive. Reductions in payments could result in rationed care, reduce quality of care. Reductions in payment rates could result in lower supply of medical providers. Keeping financial payments to providers neutral could actually avoid any impact on availability, but it would also may negate, of course, the potential savings from providers not having to do the billing. Lastly, it does say in the CBO report that a single payer system might give providers new opportunities to lower their costs through administrative savings. Marc notes in frustrated conclusion that the CBO report devotes just one short paragraph, 3 sentences, to the possibilities of how a single payer system might reduce the costs of the current system. This 3 sentences contrasts with 2 full pages of concern about the possible financial impact on providers. So if there are questions, I'll actually start with one question. Can you name 2 things made of pure gold? Okay, I can see that stumped you, but here are 2. The Nobel Prize and the No-Bill Prize goes to Marc Betz for his work on universal health care. So now I'll
Thank you,
stop sharing.
Warren.